Good day, everyone. Today I will discuss an overview about complement deficiency disorders, a group of conditions caused by defects in the complement system, an important part of innate immunity. In this presentation, I will briefly review their causes, formation, pathogenicity, detection, clinical manifestation, and other several things. The complement system is an important part of the innate immune system and consists of more than 30 plasma proteins. These proteins normally circulate in an inactive form and become activated in a cascade when they encounter pathogens or immune complexes. The complement system has three main functions. First, it enhances phagocytosis by opsonizing pathogens, mainly through C3b. Second, it promotes inflammation through C3a and C5a, which recruit immune cells to sites of infections. And third, it directly destroys microbes by forming the membrane attack complex MAC, which creates pores in the microbial cell membrane. Together, these mechanisms play a crucial role in protecting the body against infections. This figure shows the three pathways of complement activation: the classical, lectin, and alternative pathways. The classical pathway is triggered by antigen antibody complexes. The lectin pathway starts when mannose binding lectin binds to microbial sugars, and the alternative pathway is activated directly on microbial surfaces, although they start differently. All three pathways converge at the formation of C3 convertase, which activates C3. This is a key step because C3 generates important effector molecules. The cascade then proceeds to activate C5 and ultimately forms the membrane attack complex MAC, composed of C5 through C9. The main outcomes of complement activation are opsonization by C3b, which enhances phagocytosis, inflammation mediated by C3a and C5a, clearance of immune complexes, and direct lysis of pathogens through the MAC. Together, these mechanisms help protect the host from infections. An overview of complement deficiency. Complement deficiency occurs when one or more complement proteins are absent or not functioning properly. As a result, the immune system becomes less effective, leading to an increased risk of infections and autoimmune diseases. These deficiencies can affect different parts of the complement pathway. Deficiencies of the classical pathway, such as C1, C2, and C4, are commonly associated with autoimmune diseases, especially lupus. Deficiencies of the alternative pathway, including factor D, factor B, and properdin, increase susceptibility to bacterial infections. Terminal pathway deficiencies involving C5 to C9 prevent the formation of the membrane attack complex MAC and are strongly associated with recurrent Neisseria infections. Therefore, the clinical manifestation depends on which complement component is attacked. Clinical manifestations of complement deficiencies. The clinical manifestations of complement deficiencies vary depending on which component of the complement system is affected, as we said in the previous slide. First, classical pathway deficiencies, including deficiencies of C1, C2, and C4, impair the clearance of immune complexes and apoptotic cells. This leads to the accumulation of immune complexes in tissues and increases the risk of autoimmune diseases, particularly systemic lupus erythematosus. Patients may also experience recurrent infections, especially with encapsulated bacteria. Second, deficiencies of the alternative pathway, such as factor D, factor B, and properdin deficiencies, reduce the body's ability to amplify complement activation. As a result, patients become more susceptible to recurrent bacterial infections, particularly infections caused by encapsulated organisms. Third, terminal pathway deficiencies involving C5 through C9 prevents the formation of the membrane attack complex, which is also known as MAC. Since MAC is responsible for directly lysing bacteria, these patients have a markedly increased risk of recurrent infections caused by Neisseria species, especially meningococcal diseases. Finally, C3 deficiency is considered one of the most severe complement deficiencies because C3 is the central component shared by all complement pathways. Deficiency of C3 results in severe recurrent pyogenic infections, poor opsonization of pathogens, and increased risk of immune complex diseases. So, in summary, complement deficiencies commonly present with recurrent infections, autoimmune manifestations, or both, and the specific clinical feature depend on the affected complement component and pathway. To understand the pathogenicity of complement deficiency, we need to remember the normal functions of the complement system. When complement proteins are absent or defective, the body's ability to fight infections is significantly reduced. One important problem is reduced opsonization. Without enough C3b, bacteria are not properly marked for destruction, making it harder for phagocytes to recognize and remove them. Another consequence is a weaker inflammatory response. Lower levels of C3a and C5a mean fewer immune cells are recruited to the site of infection, which slows the body's defense against pathogens. In addition, deficiencies in C5 to C9 prevent the formation of the membrane attack complex, which normally kills bacteria by creating pores in their cell membranes. This is especially important for protection against Neisseria infections. The complement system also helps clear immune complexes. When this function is impaired, immune complexes can accumulate and contribute to autoimmune diseases such as lupus. Complement deficiency weakens several key immune mechanisms, leading to recurrent infections and an increased risk of autoimmune disorders. Diagnosis of complement deficiency focuses on evaluating how well the complement pathways are functioning. The first screening test is the CH50 test, which assesses the classical pathway. If the CH50 level is low or absent, it suggests a deficiency in one or more components of the classical or terminal pathway. The AH50 test is used to evaluate the alternative pathway. A low AH50 results indicates a defect in one of the alternative pathway components. If an abnormality is detected, specific complement proteins assays can be performed to measure individual proteins, such as C3, C4, and C5 through C9. This helps identify the exact deficient component. Genetic testing may also be used, especially in inherited cases, to identify mutations in complement related genes and confirm the diagnosis. The prognosis of complement deficiency is generally good when the condition is diagnosed early and managed appropriately. Early diagnosis is important because it helps prevent recurrent infections and long term complications. Management mainly focuses on preventing infections. Vaccination plays a key role, especially against high risk pathogens such as Neisseria, meningitis, Streptococcus pneumonia, and Haemophilus influenza type B. For patients who experience frequent or severe infections, prophylactic antibiotics may be prescribed to reduce the risk of future infections. Patients should also be educated to seek medical attention whenever signs of infections appear. In some specific complement deficiencies, targeted treatments are available. For example, C1 inhibitor replacement therapy is used in hereditary angioedema to prevent and treat attacks. Overall, with appropriate vaccination, preventive care, regular monitoring, and patient education, most individuals with complement deficiency can lead healthy lives and have a favorable long term prognosis. Case example. This case involves a 16-year-old boy who developed meningococcal meningitis for the second time because recurrent Neisseria infections are unusual in healthy individuals. Physicians suspected an underlying immune deficiency and performed complement testing. The results showed a normal C3 level but an absent CH50, indicating a defect in the terminal complement pathway. Further testing confirmed a C8 deficiency, which is one of the components required to form the membrane attack complex. Without a functional MAC, the immune system cannot effectively destroy Neisseria bacteria, making patients more susceptible to recurrent meningococcal infections. Management included meningococcal vaccination, long term prophylactic antibiotics, and patient education about seeking immediate medical attention if symptoms of infection occur. This case demonstrates the strong association between terminal complement deficiencies, particularly C5 to C9 deficiencies, and recurrent Neisseria infections. It also highlights the importance of early diagnosis and preventive management to reduce the risk of future infections. In the summary, complement deficiencies are rare immune disorders that increase the risk of recurrent infections, autoimmune diseases, and hereditary angioedema. Early recognition and diagnosis are important because preventive measures such as vaccination, prophylactic antibiotics, and targeted treatments can reduce complications and improve long term outcomes.